Hello everyone, I am Pierre Bertholon, an ENT neurologist in Saint-Étienne, France, and I will be talking about management of vertigo in the emergency department. As you know, vertigo dizziness is a common complaint that accounts for approximately 3% of emergency department visits. Of course, diagnosis of a patient suffering from vertigo is challenging as it may be due to various disorders, usually in the fields of otology, neurology, but sometimes also psychiatry, internal medicine. However, in emergency, it's easier to make an accurate diagnosis as vertigo should be associated with objective signs, especially oculomotor abnormalities. The objective of this presentation is to demonstrate that patient's history and otoneurological examination at bedside is extremely reliable to differentiate a peripheral vestibular disorder from a central lesion. It is essential to remind that vertigo due to a peripheral disorder, an ENT disorder, has mainly two different presentations. Either a dysfunction of a canal, as can be observed in benign paroxysmal positional vertigo. Then the patient complains of brief, less than 1 minute, vertigo which is positional, and positional maneuvers should trigger a typical positional nystagmus according to the canal involved, posterior canal, horizontal canal. The second presentation is a dysfunction of the whole inner ear or the vestibular nerve, and patients complain of the spontaneous vertigo during at least 20 minutes, sometimes a few days, as can be observed in a crisis of Meniere's disease, labyrinthitis, vestibular neuritis. Then the patient should have a typical peripheral vestibular deficit with a spontaneous horizontal torsional nystagmus associated with a contralateral body deviation. One of the most difficult diagnostic challenge is in emergency to differentiate a benign vestibular neuritis from a dangerous stroke in the posterior fossa that can present with isolated vertigo. Indeed, cerebellar infarction may mimic a peripheral labyrinthine lesion, and that's a challenge. It should be emphasized that systematic imaging of the head of all patients with vertigo is neither practical nor useful. Indeed, systematic brain scan was positive in less than 1% of patients with vertigo, and brain MRI was positive in approximately 12% of patients with vertigo. It is even worse for laboratory abnormalities. So, imaging and laboratory testing should be appropriately guided by the clinical evaluation, which means history taking of symptoms and bedside otoneurological examination for signs. The diagnosis relies on history taking, and there is more and more accumulating evidence that trying to clarify the type of vestibular symptoms, dizziness, vertigo, unsteadiness, or lightheadedness, is difficult in emergency and of limited clinical utility. On the contrary, it is easy to ask for a few simple questions on the duration of the vertigo. Is it less than 1 minute, more than 20 minutes, a few days? Is it the first episode, or is it a recurrent, or in the past, previous vertigo episodes have occurred? And also, we should look for the triggering factors, particularly the movement of the patient. If it happens only on arising from bed, for example, it's an argument for orthostatic hypotension, whereas if it also happens when lying back or rolling in bed, it's an argument for BVPV. You should also systematically ask a few simple questions in order to search for neurological disorders. the patient, did the patient complain of clumsiness, paresthesia, dysarthria, which of course point to a neurological disorder. So this is a very simple algorithm on the symptoms, where you can see isolated vertigo, vertigo with auditory symptoms, and vertigo with neurological symptoms. For isolated vertigo, if you have brief, less than 1 minute, positional vertigo, especially in bed, it's usually BPPV. If you have spontaneous vertigo with a unique episode lasting for days, it's usually vestibular neuritis, but be aware of the risk of a cerebral infarct in the territory of the posterior inferior cerebral artery. If you have a recurrent episode of spontaneous vertigo, it can be vestibular migraine. If you have vertigo with auditory manifestation, which is spontaneous, with a unique episode lasting days, it can be labyrinthitis, but the context, the clinical context, is often evident. It can also be a very rare cerebral infarct in the territory of the anterior inferior cerebral artery. If the spontaneous vertigo is recurrent, with episode lasting more than 20 minutes, it's usually a Meniere's disease. And always be aware of the possibility of vestibular schwannoma. Of course, if vertigo is associated with double vision, paresthesia, clumsiness, dysarthria, dysphagia, dysphonia, then there is strong argument for central neurological disorders, especially a stroke. Let's move on now to the bedside examination to diagnose the signs of the patient. At least 2 recent series show the importance and sensitivity of clinical examination compared to imaging tests in acute vertigo patients. The first series is from a neurological department using a 3-step bedside oculomotor examination. This takes approximately 2 minutes and you need no device. The second series is from an ENT department using a 4-step bedside examination, including oculomotor and body examination. You only need Frenzel glasses. So for the first study, the INS study, the 3-step bedside ocular examination performed on 101 consecutive patients with acute vestibular syndrome includes the simple observation of nystagmus in different positions of gaze at fixation, the cover test to search for a skew deviation, and the Almaghi test in the horizontal canal plane. And this oculomotor examination was compared to neuroimaging, mainly MRI. I will not focus on all the article, but just on the conclusion, which was that a 3-step bedside oculomotor examination appears more sensitive for stroke than an early MRI in acute vestibular syndrome. Probably one of the main reasons is that initial MRI in the first 24 hours can be fastly negative. The second study, the standing study, has been performed in 292 consecutive patients with vertigo, randomized in a standing group and a control group. And this patient had a 4-step bedside examination, including spontaneous nystagmus under Frenzel glasses, positional nystagmus observed during Dixolpide testing and supine roll test, Almaghi testing in the plane of the horizontal canal, and analysis of body stability with the argument that a patient which is unable to stand alone with eyes open should be considered as a central neurological patient. And so this standing algorithm shows good reliability and very high accuracy in excluding dangerous disease in the hands of emergency physicians that have been trained for this four-step bedside examination. So based on these two previous studies, we regularly use a set of 5 basic bedside tests. Analysis of eye movement in different positions of gaze as well as ocular pursuit, analysis of nystagmus under video ensembloscopy, horizontal Almaghi testing, position maneuvers, and finally, analysis of postural stability by Romberg or Fukuda testing. The analysis of eye movements in different positions of gaze is simple to perform, as you just have to ask the patient to fixate a target, that can be a pencil, in the different position of gaze, and then after you ask the patient to follow this moving pencil in order to appreciate the ocular pursuit. Sometimes immediately you have abnormalities such as a gaze-evoked nystagmus, a downbeat nystagmus, an internuclear ophthalmoplegia, and this immediately affirms a central neurological disorders and sometimes even the exact localization of the lesion. Of note, smooth pursuit is often affected by central neurological disorders, in particular cerebellar lesion. The most frequent central nystagmus is the gaze-evoked nystagmus. This nystagmus develops because of an inability to maintain fixation in eccentric gaze. So when you look to the right, you have a right horizontal nystagmus, and to the left, a left horizontal nystagmus. This is what we can see in this patient with the cerebellar disorders, a right horizontal nystagmus in the right gaze, and a left horizontal nystagmus in the left gaze. This gaze-evoked nystagmus is usually associated with a saccadic pursuit, and so you should test these two tests in the same time. It is the most frequent central nystagmus. Another central nystagmus is the downbeating nystagmus, which increase in lateral gaze, and sometimes is only present in lateral gaze. Here is this patient, which has a downbeating nystagmus when looking to the right, and which also has a downbeating nystagmus when looking to the left. This central nystagmus, this is always a central nystagmus, which is usually associated with vertical osteopsia rather than vertigo, and often also disequilibrium. This nystagmus is interesting because it localizes the lesion to the inferior part of the posterior fossa, inferior part of the cerebellum, whatever the etiology. It can be a chiari malformation like on this MRI, it can be cerebellar degeneration, it can be vascular pathology, it can be intoxication with anti-epileptic drugs such as carbamazepine, it can be vitamin B1 deficiency. Second test, the analysis of nystagmus under video ensembloscopy, which can be static or even with a portable device. As the peripheral nystagmus is increased or becomes apparent when fixation is eliminated, it is necessary to use either Fresnel lenses or a better video ensembloscopy. And a peripheral vestibular nystagmus, due to lesion of the inner ear or vestibular nerve, is usually horizontal torsional. This nystagmus does not change direction with change in gaze position, and is increased when the eyes are deviated in the direction of the fast phase. Here is a typical horizontal, left horizontal nystagmus, which do not change direction in different position of gaze. This is a typical nystagmus due to a right peripheral deficit, vestibular neuritis on this patient. And of course, this peripheral nystagmus is usually associated with a body deviation when eyes closed to the opposite side of the fast phase of the nystagmus, the typical peripheral vestibular deficit. The Almagui testing is performed with rapid head rotation to the left or to the right, because it is essentially reliable at bedside for the horizontal canal. At bedside, it's difficult to perform the vertical canal. So, when you have a normal ear function, when you perform an abrupt head thrust to the right, and you have asked before the patient to look at your nose, to fixate your nose, you should have a stable vision of the patient, which is able to stay straight on your nose. So the eyes are not moving in the orbit, they are stable. If you have a right vestibular deficit, when you perform this rapid head thrust to the right, then the eyes will move with the head to the right. And as you have asked your patient to maintain fixation on your nose, the patient will do a corrective saccade to the left. And so, if you have a corrective saccade to the left, you probably have a right vestibular deficit. And on the contrary, if you have a central neurological disorders, usually you have no corrective saccade, and so you have a normal Almagui testing. So this test is very interesting to differentiate a peripheral from the central vestibular disorders. The positional maneuvers are, of course, essential to diagnose BPPV, which remains the first cause of vertigo, and the maneuvers should be performed in the plane of the posterior canal, the dick supine maneuver, and the horizontal canal, head rotation in the supine position. Of course, the direction of the nystagmus is essential to diagnose the canal involved. So here is a typical right posterior canal BPPV. This is a roughly pixel pipe maneuver. And after a few seconds latency, you have this typical rotatory upbeating nystagmus, which will last for a few seconds. Sometimes you will have a different nystagmus, which is horizontal, and this is typical of BPPV of the horizontal canal. Here you have a right horizontal nystagmus when moving the head to the right, and so this is the geotropic form of horizontal canal BPPV. Of course, the best maneuvers for horizontal canal BPPV is the head rotation in the supine position. And when you move the head of the patient to the left, you have a reversal of the nystagmus, which is left horizontal beating when the head is moved to the left. So this is a typical horizontal canal BPPV in its geotropic form. You can have another form which is a little more rare, which is the ageotropic form of horizontal canal BPPV. And in this form, when you move the head to the when you move the head to the left, you have a right horizontal nystagmus, and so this nystagmus is ageotropic. And when you move the head to the right, then you will observe a left horizontal nystagmus. So this is a typical ageotropic form of horizontal canal BPPV. Now let's move on to the analysis of postural stability by Romberg and or Fukuda testing. If possible, the Fukuda testing is probably the best test because it has been quantified. You ask the patient to walk on the spot with feet together, with eyes open, and after with eyes closed. And you ask the patient with eyes closed to do 50 steps, and the rotation of the body should be less than 30 degrees. Of course, examination of posture and gait is useful in the diagnostic of the disease patients, but is less important than eye movements or position maneuver. However, examination of posture and gait sometimes can immediately differentiate a peripheral from a central vestibular disorders, in particular when patients are unable to stand with eyes open, which should be considered as a central sign. And also, examination of posture and gait is more important than eye movements to diagnose psychological disorders, and this diagnosis should be usually be performed at glance. So, here is an example of a teenager which is hospitalized in the pediatric department for vertigo and dizziness, and as you can see, there is a psychological component in the disequilibrium that you can observe. And of course, it's important to make this diagnosis to take in charge the psychological component. And as you can see, a few days later, there is no more disequilibrium, and this teenager is now doing well. So, we can use a very simple algorithm for signs, which is if the spontaneous nystagmus is present, sometimes it's obviously central, gazebo nystagmus, nystagmus which is purely vertical or purely torsional, and so it's central. Sometimes the nystagmus is possibly peripheral because it's horizontal torsional. Then you should perform the Almagui testing. If you have a corrective saccade, if the patient is able to stand with eyes open and to deviate on the other side of the fast phase of the nystagmus, then you should conclude for a peripheral vestibular disorders. But if there is no corrective saccade or the standing position with eyes open is impossible, then you should evoke a central disorders and go on with the examination, in particular an MRI scan. And if spontaneous nystagmus is absent, then you go on with the positional maneuvers. So this set of 5 basic bedside tests is usually able to differentiate a peripheral vestibular disorders from a central lesion, and often to approach the underlying etiology. Of course, these 5 tests can be completed according to clinical needs by other tests, such as, of course, the cover test, head checking, vibratory test, fistula test, search for cerebral dysmetric, and so on. Of course, this clinical evaluation should be completed as soon as possible by audiological testing, as audiological test often immediately orientates the diagnosis. For example, normal pure tone audiometry is compatible with BPPV, vestibular neuritis, vestibular migraine, cerebral stroke in the territory of the posterior inferior cerebral artery, and also Wallenberg syndrome. if you have a sensory neural hearing loss on the low middle frequency, this is a strong argument for Meniere's disease at an early stage. If you have a sensory neural hearing loss on middle high frequency or even total deafness, here on the right side, it is compatible with a vestibular schwannoma, with labyrinthitis, with a temporal bone fracture. On the left side, it is compatible, the same type of hearing loss as the slide before. It is compatible with an intralabyrinthine hemorrhage here, or a cerebral stroke, which is hopefully rare in the territory of the antero-inferior cerebellar artery, which this artery supplies the inner ear. And if you have a mixed hearing loss, like here, this is a strong argument, if associated with vertigo, for a third window mechanism, as can be observed in descent of the superior canal or enlarged vestibular aqueduct. So, in conclusion, based on history taking and simple bedside tests, clinicians should be able to decide whether the patient is possibly suffering from a stroke, a neurological disorders, and should add rapidly a brain MRI, whether the patient is affected by a non-threatening disorders for which treatment can be started, BPPV, vascularitis, Meniere's disease, vestibular migraine, whether the diagnosis is still unclear, requiring other appropriate audiovestibular exploration, imaging, laboratory testing. So, to conclude, the take-home messages should be: do not hesitate to see patient in emergency. It is more efficient, as you should have objective signs, in particular oculomotor abnormalities. Oculomotor examination and fixation is essential to diagnose a central disorder. Venous endoscopy is essential to search for a peripheral nystagmus. Use the Almagille test in the horizontal plane. It is essential to differentiate the peripheral vestibular disorders from central one. Use the standing position with eyes open and after with eyes closed. And remind that a patient that is unable to stand with eyes open should be considered as a central neurological patient. According to the clinic, perform additional testing, head checking, vibratory tests, and so on. Of course, pure tone audiometry is essential to immediately orientate the diagnosis. Be aware of the limit of the CT scan and even of MRI to diagnose the central disorders. Keep in mind that most of your difficulties will come from the cerebellum, because in this localization, you may have isolated vertigo of central origin. And vertigo or disequilibrium, when associated with confusion, is really an emergency, because it's usually due to a cerebellar infarct that carries a vital risk that can be sometimes by compression, due to compression, that can be usually prevented by a neurosurgical operation. Well, thank you for your kind attention.